Hi, I'm Dr. James Thomas. I'd like to go over the topic of neurolaryngology, which is an incredibly broad topic. I'm going to introduce it by focusing on one nerve and one muscle with the proposition that visual neurolaryngology, that is looking with an endoscope and looking carefully, can be as accurate as EMG diagnosis of what's going on in the larynx. And whether you choose one or the other, I think just depends on your equipment and your familiarity with each. But let me show you and share with you what I do with visual neurolaryngology. We're going to focus, in this case, on the lateral cricoarytenoid muscle. You'll be seeing this diagram during the talk. And this is an imaginary cut end of the recurrent laryngeal nerve, and we could, as if we could look at what the fibers are doing. And what would happen if there's an injury to just one branch of the nerve? What would happen? This case was sent to me by a colleague, and we're going to use it for exploring this idea of using vision to diagnose nerve problems. Let's look at it.
And
I think the most common conclusion is when you see something not moving well is to jump to the diagnosis of there's a vocal cord paralysis. And often the next question is, which side? We might jump to the conclusion that it's the left side, but I actually think that's the wrong conclusion because it was the wrong question. Let's back up a little bit. Instead of asking, is this paralyzed? Let's try to be more precise in our analysis. And the way we're going to get at precision is to focus our eyes on one particular structure and what it does at a given time. And that structure for this talk is going to be the vocal process on the left and then on the right. So here's the video. The patient's breathing. We saw it moving around or jumping around. How are we going to get to what's going on with that? And if we look here at the LCA, I'm imagining one possible explanation for this incomplete motion is that there's been a pressure injury to the nerve and all of these branches are weak, but specifically maybe the LCA branch is weak and only a few fibers are getting the signal to it. But there might be another explanation, and that could be that this was injured some time ago and there's still some LCA fibers getting to the joint, the vocal process, but maybe there's this crossover and there's some PCA fibers in there fighting against it or pulling it the wrong way at the wrong time. So that's my imaginary two hypotheses for what might be going on. So let's watch it again. And this time, we're looking at the same video, but we're going very slowly, and we're going to look at it repetitively. So our first task is to isolate inspiration and ask ourselves what's going on with the left vocal process. Expiration, inspiration, inspiration, inspiration. So during inspiration, we clearly see the appropriate direction. So the PCA muscle must have some activity. So it's incomplete. It's not going all the way out to the side. Really, the patient complaint is about hoarseness, not dyspnea. So in some sense, for this particular case, we're actually not worried how far out it goes to the side. We actually want to know what it does when the LCA activates for phonation. So in a way, we can ignore this injury of the left vocal process doesn't open all the way. So our second task is to look at the vocal process during phonation. Let's watch this slowly and over. So here's the onset of phonation. Left vocal process is moving toward the midline. Yes, the PCA muscle is somehow impaired, but the LCA actually is moving to the midline and probably even past the midline. So it's functioning pretty darn well. Maybe it's completely normal, or maybe there's a few PCA fibers crossed over, but the dominant effect is it's getting to the midline and it's probably even getting past the midline. So now we're going to turn our attention to the other side, the right vocal process, and we're going to watch that little white spot, what it's doing. All right, we watched the inspiratory task 3 times. I would say pretty clearly the right vocal process is opening all the way. Now during phonation, the right vocal process comes in, although it comes in pretty incompletely. I think there's 2 possibilities here. And when we're watching the right vocal process, we're not only watching, does it get to the midline, but does it get to the midline by rotation? And in this case, I think it's going not to the midline, but it's getting pulled, and actually it's never rotating. It's being pulled over, and it's being pulled over incompletely. So I'll give 2 hypotheses here. One is that there's nothing in the LCA muscle and it's the enteroarytenoid pulling it over, or maybe there is a little bit. It clearly is adducting some during the onset of phonation. Slightly related to this, meaning there's more tension on the left side than the right, so I suspect there's some injury to the thyroarytenoid muscle, but it's clearly not severely atrophic, so I'll postulate that this on the right side is probably some injury that includes both anterior branches of the recurrent nerve, and they're quite closely related to each other, so it's very easy to injure both of these branches. It seems like there's a minor weakness of the thyroarytenoid muscle. There's a more major weakness of the right lateral cricoarytenoid muscle. So I think the injury on the left side is an old injury. It has reinnervation, impairing the overall range of motion, but it's actually quite strong during phonation. And the right side has probably the more recent injury, which is just a weakness. So matching it up with their complaint, that's the current injury. The lateral cricoarytenoid muscle, we're imagining it fires in the brain and moves a muscle. And when does it fire? Well, it fires during expiration each time, and it fires during phonation. So we actually have 2 opportunities during our laryngoscopy exam to assess the lateral cricoarytenoid muscle, watching respiration and phonation. And we can imagine that this can get injured, it can get cut, paralysis, it can be pressure, paresis, some sort of degree of partial. It could be that over time it reinnervates, and depending on when we see it in time, it could go back to completely normal. Or the reinnervation could be somehow disordered with crossover between abductor and adductor muscles. One option is synkinesis, that we kind of get a tension of the joint where it doesn't move much, or we get actual motion in the wrong direction. If the PCA fibers completely go to the LCA muscle, it'll move in the wrong direction or at the wrong time. So that's dyskinesis. Let's take a look further at how we would differentiate which of these findings we think is going on. Well, we'll do that by a number of ways. We've already talked about focusing our eyes on a joint, and we can watch that joint, as I said earlier, during an event, inspiration, expiration, or phonation. So it's important to record breathing. And when we do that, we have a control, that is the opposite side. So we can compare left to right timing. We can compare left to right, what's the arc of rotation, comparing one side to the other. and whether that is complete, which it needs to be for phonation, and it's partial for expiration depending on your need for positive end expiratory pressure. I briefly mentioned the concept that there can be translocation instead of rotation, and that could occur because maybe some lateral cricoarytenoid fibers are going to the PCA muscle, so your brain says rotate in, but it keeps it out because of this competitive firing. Or it could be that we get some movement of the joint, but it's because there's intrarytenoid compensation that's helping it to move, but it helps it incompletely. It could be that we only get a view of the membranous vocal cords, and we don't actually see what's going on with the angle of the joints, and so we can think that it's closed when in fact there's overcompensation by the opposite side, and we will find we have to get into the posterior commissure to actually assess whether this complete closure is normal closure. All right, what's going on here? Another case. Well, let's watch respiration. Compare the two sides. We can see one side, the right side, moving through a certain range, and we'll call that normal compared to, let's say, the left side, which is moving in the right direction each time, but through a very, very reduced range. So even though the problem could be with phonation, we can get a lot of information from respiration. We really want to get into the posterior commissure. You need topical anesthesia to do this kind of exam because you're going to have to get your endoscope in underneath the arytenoids to see this configuration in the posterior commissure. But this is really the sine qua non of how you identify this. I'm slowing the video down, putting it in the posterior commissure. Again, if you only look at the membranous cords, they look normal. But look at that angulation of the right vocal process way past the midline. And look at the angulation of the left vocal process. It is out. So I've put together on this one exam the three different pitches, high, medium, and low pitch, because there's compensation from the cricothyroid muscle. At high pitch, we're getting pull, and they'll be somewhat close together, but we can see the angulation of the left side out. As we drop down in pitch, the left side falls out further and further, but also the right side goes over more and more as we drop down in pitch. And that's why a person who has a minor injury of this can be good in the morning and bad in the evening. The compensatory side has been working hard all day. If we look at this closure and we focus on the membranous cord, again, it's going to look symmetric, looks pretty good. We have to turn our eyes, after examining the membranous cord, to the vocal processes and see what's going on there. And I'm going to slow down the video, and you can, of course, see a timing difference here. That is, the right side comes closed first, and the left side comes closed a little bit later, but also the right side is leading with the joint, and the left side has a little bit more just pull inward from intrarytenoid help, making up for a weak LCA muscle. And we'll watch the same person here during respiration, and I think sometimes it's even more apparent because there's less stimulation from the nerve here, and we can see the difference in closure during expiration. This is a very weak lateral cricoarytenoid muscle. Let's do one more example here. We can see, if I slow this way down, the rate and final arc of closure, that is, both sides come in initially, and then the right side has the final closure. Here is a person with a mild weakness of the right side. How do we conclude that? Well, let's watch the closure. They close, and then the weak right side collapses laterally. And as we go up in pitch, we'll see the cricothyroid muscle compensate and bring them back into alignment. So closure, going up in pitch, cricothyroid muscle gradually pulls them back into alignment. Perfectly aligned at high pitch. Here we have spontaneous voice loss 4 years ago. And now when we look at this, you might say this is quite confusing. Look at the twitchiness of the right side. But the key here is to focus. And we'll do that by recording it, slowing down the recording, watching respiration, specifically focusing on inspiration. Is the timing of adduction correct? And we're only going to look at the right side initially to see what's going on. So there's the sniff in. Well, with sniff in, we're getting adduction. So we can tell that PCA muscle fires, rotates it, and then the PCA muscle does pull it a little bit laterally. And I'll point out that this sniff and the rotation of the joint is not Bernoulli effect. This is active rotation. So a sniff strongly activates PCA fibers that go to the LCA muscle on the right that rotate the joint towards the midline. That's my summary, or let's say, rather than a summary, that's my introduction, and you've learned that you can tell what's going on with LCA and PCA fibers going to the LCA muscle by watching the joint slowly, repetitively, in isolation, and that's an introduction to visual neurolaryngology. I have to say, if you'd like to know more, I'm giving a course this October, Portland Diagnostic Laryngology Workshop, where instead of working on surgery, we're going to work on focusing our minds on how to find things that ultimately might need surgery. Thanks for listening.